So this morning I'm going to do a presentation on risk adjustment using the CDPS model. So risk adjustment. So why am I talking about risk adjustment? So a couple reasons. One is that the risk adjustment is pretty essential for effective managed care in Medicaid. And so risk adjustment is very prevalent in states that use a lot of Medicaid managed care. It's being used in the Medicare program. It's being used in the state health exchanges, so it is something good to know about. It's also useful to have algorithms, diagnostic algorithms, when working with the Medicaid data. So if you're doing a very focused study, on newborns and healthy mothers, you might not need risk adjustment. You've kind of got a fairly homogeneous population. But if you're looking at larger, like groups of people who are disabled more generally, or other types of groups, you might want to control for illness severity, and this gives you a way of doing that. And so it's a useful way of kind of taking all those ICD-9 codes and doing something manageable with it. And so that's why I want to talk about it. So this is what I'll talk about in the next half hour. We're going to talk about what are the goals of risk adjustment, why do we do it. I'll give you a brief history of it. And then I'll show you kind of how it operates, and I'll talk about other ways in which risk adjustment might be helpful. So what is risk adjustment? So we think of it as kind of two parts. One being a health-based risk assessment. So that's measuring illness burden at the individual level using the data that you have. And so typically that'll include demographics and diagnoses. Some models will also use pharmaceutical claims to measure illness severity kind of based on the pharmacotherapy you are receiving. And then some models will also include data on, say, cognitive and functional limitations, which would be important if you're looking at like home and community-based waiver programs, long-term care, things like that. And then risk adjustment is using that data to adjust something. So these models were developed to adjust capitated payments to health plans enrolling Medicaid beneficiaries. It can be used to risk adjust other outcomes like hospitalization rates and things like that. So it's kind of an adjuster for illness severity. And why is it necessary? And so you hear about the different rules, the 2080, the 1060. These are some statistics from disabled Medicaid beneficiaries. The top 1% accounting for 30% of the expenditure. So we know, the distribution of healthcare utilization expenditures is highly skewed with a long, fat tail. They call it kurtotic. So you have kind of small numbers of people accounting for large proportions of cost. And the problem with that is that if you're in a capitated payment system where you're not risk adjusting, you're receiving the same payment per person, it gives you a huge incentive to avoid sick people, right? You can do all the care management you want, but really you're going to get hammered if you enroll people that are sicker on average. And so what risk adjustment tries to do is to minimize those incentives for cream skimming and to make equitable comparisons across health plans, kind of level the playing field in a sense. And also then provide adequate financing for programs that do enroll people that are sicker than average. So if you think about where you are in your kind of regional area, there might be a hospital in an urban area that maybe serves kind of the lower income residents, maybe a place that attracts sicker individuals, like a specialty hospital, a children's hospital, something like that. And if you have health plans associated with those academic medical centers or other areas, they're not going to do as well financially if they're receiving the same amount of payment per person. So it's both to kind of minimize, plans' active, marketing to the healthy, and kind of adequately finance those that do attract a sicker population. So kind of both sides of it there. And this is kind of, as I was talking about, some reasons why a particular health plan or network might have a sicker population. There is, again, affiliated with an academic medical center, cancer center, maybe places that are renowned for their diabetes care might attract sicker groups or those types of groups. And that would result in higher spending. And it might have certain geographic regions, might have higher case mix enrollees. So urban areas might look different than rural areas, and suburban areas, and so on. So the idea of, there are risk variations out there, and here's some factors that drive it. And the advantage of implementing an effective kind of risk adjustment system is you kind of use that health assessment to measure the illness burden at the individual level, and then you assemble individuals into groups based on health plans in which they enroll, and then you have metrics to say that, well, this plan has a higher risk burden than this plan, and then you can use those metrics to adjust the capitated payment. So the health plans that enroll the sicker beneficiaries would get a higher capitated payment. So it'd still be capitated. So it'd still be one payment per person, providing kind of the incentives for the risk plan to manage that care most effectively. But the payment would be higher if you had sicker individuals enrolling in it. And we calculate those metrics and make those adjustments using data and claims typically. And the most predominant source of data there would be with the diagnoses. And you saw the diagnostic field and perhaps used it yesterday in the inpatient claims that have diagnoses on them, and a lot of the OT claims will have diagnoses on them as well. In the MACs, the OT have 2 diagnoses, and the inpatient have, I think, up to 9. Although all 9 aren't always filled. So this is the plan. We're going to promote efficiency and reduce the incentive for risk selection. Any questions on why we do risk adjustment and why it's necessary, the benefits? So what are the key ingredients for successful health-based payment? No cheating if you're looking on the slides. So 3 things. No. So this one is equitable data. What's the second one? Okay, the second one is equitable data. And you can guess the third one. Equitable data. So data becomes a huge issue, right? So you're basing all these models on the diagnostic profile of the beneficiaries. You really need to have a fair or equitable or equal data collection system. So if one plan isn't collecting diagnoses very well, they're going to look very healthy when that's not true. And if another plan invests a lot of money in making sure everyone's got all their diagnoses covered, which plans do, then again, it's not equitable. So especially when this was first rolling out, and they continue to look at changes over time in health plans and try to be cognizant. I know Kaiser had a big effort at one point investing in coding, right? Training the providers to code or the medical assistants and things like that. And it still goes on. Hospitals invest a lot of money in coding. It drives the GRG payments, so they're kind of doing that already. And we just kind of need to be aware of that and make sure like some other health plans aren't disadvantaged because of it. But what ends up happening is everyone really has an incentive to code. But what is happening is managed care is getting better at coding now than fee-for-service. So they've kind of surpassed fee-for-service in their coding. And if you look at Medicare Advantage, the payments for Medicare Advantage plans have been going up and up and up. And because it's linked to fee-for-service, they're getting more and more payments. But it's because they're coding more. So eventually, they're going to need to fix that. But so far, they don't want to hear about it. Rick Kroenig is trying to tell them that, and eventually maybe they will make an adjustment. Here's the history of the risk adjustment. So these models were first developed in the 1990s. They're developed for the Medicare program, the ACGs and the DCGs. Medicare promoted these early, but adopted the models fairly later. Medicaid started in 1997, and then Medicare Part C started in 2004, and then Part D, the pharmacy part, started in 2006. So Medicaid got a big jump start. There's more managed care in Medicaid overall than in Medicare. Medicaid we saw was up to about 50%. I think Medicare is still about under 20. Here are different states and different populations that they risk adjust. Some adjust basically most people, SSI, the disabled and TANF. Some have done just the disabled, and some have done just the TANF. But most do them combined. And then here are the models. And they've only, most of the places have used CDPS because it is a Medicaid-specific risk adjuster. And for a long time, we gave it out free. But there are a couple other models that are used too. And the Medicaid RX is our pharmacy-based model, our NDC code-based model. And so I'll talk about both of those a little bit. Risk adjustment and healthcare reform, their risk adjustment is being used in the state health exchanges. There is a risk adjustment model specific for the healthcare exchange that you can download from CMS, somewhere. I'm not sure exactly where, but if you can't find it, you can email me, and I have it in my email somewhere. And then Medicaid programs are overwhelmingly using managed care for the Medicaid expansion, and they'll need to be doing risk adjustment in there as well. There's some other areas they're looking at this. Some of the dual eligible pilot programs are looking into risk adjustment models. There's interest in trying to risk adjust between home and community-based waiver services and long-term care services. There's a huge gap between the payments in those, so institutional long-term care is a lot more expensive, and it's driven by a day rate, nursing home day rate. It's driven by functional limitations, so it's kind of a different animal. And then you're looking at measuring things like functional limitations and cognitive status. But kind of managed long-term care is becoming kind of more and more of interest. And some places are getting additional data through web portals, clinician assessments, things like that, way to electronically collect these kind of self-reported data on large numbers of people. Wisconsin, I think, is doing that. So there'll be some innovations coming, hopefully. And some interest in risk adjustment and social economic status. So looking at healthcare utilization, how is that related to income? How is it related to race, ethnicity? How is it limited to, or related to English language proficiency? So some kind of interesting, kind of public health issues associated with risk adjustment. What is CDPS? So CDPS is one model. It's one option you can use. It's Medicaid specific. Alex Hauser has a model. I don't know if it's used for risk adjustment, but it's used for health-based risk assessment, and that's available from Agency for Healthcare Research and Quality, AHRQ. And then there's the DCG models, the ACG models, and so on. They're all fairly similar. They kind of all try to do the same thing. So CDPS takes looks at all the ICD-9 diagnoses, and now we're also using ICD-10. And there's about 17,000 ICD-9s, and it kind of looks at them all, uses about 6,000, and it maps them to 58 disease categories. So these are within 19 major categories, like cardiovascular, psychiatric, pulmonary, that would be a major category. And within those, it has a hierarchy, and it assigns diagnoses to one of these places. And how we did that was with a lot of regression analyses and a lot of clinical input. And a colleague and I would work together, and I'd run the regressions, and he'd run it by his clinicians, and we kind of iterate, grouping diagnoses, mostly at the 3-digit level, then into groups that had kind of similar, cost coefficients and similar clinical meaningfulness and clinical severity. And we eventually, it took us 2 years, we mapped them all. And so that's CDPS. And so it's similar to kind of the HCC models, which are built off the DXCGs that they use in the Medicare for Part C and Part D. I think Medicaid pays a little bit more attention to some of the more severe but less common diagnoses that you see in the Medicaid program among the disabled in particular. And the HCCs would puts more effort into kind of mapping out different types of cardiovascular disease, for example, because you've got more elderly, more kind of common chronic disease. So, and cardiovascular would be a big part of that. So we have kind of less detail there, but more consideration of other Medicaid-related diagnoses. And then we have payment weights that are developed on, on Medicaid, on the MAX data. And we have, separate models for disabled TANF adults and TANF children. And kind of from yesterday, why would we develop different models for the different aid categories? The cost and the utilization profile is very different. Remember, the disabled had this giant big column of all these different things, and the adults and the children were smaller. And even the adults and the children differed by a factor of 2. So, so we have different models for each of these groups. Here are the major CDPS categories that we talked about. So these correspond pretty well to the categories in the ICD-9 codebook. So, and so these are major categories: cardiovascular, psychiatric, and so on. And pregnancy is considered a chronic disease in our model, but it's important in the Medicaid program. And here's like an example of the hierarchy within cardiovascular. So the diagnoses here, very high would be things like a heart transplant or a valve transplant or a valve malfunction. So things that involve some major surgeries. Below that would be heart failure, so kind of a severe chronic condition that requires ongoing management. Below that would be kind of a heart attack, a little bit also important, but a little bit more acute. And then below that would be hypertension. So those are just examples of diagnoses within those categories. We kind of chose ones that were fairly prevalent that kind of help anchor the category. But within these, it's hierarchical. So if you have both hypertension and an AMI, we'll just code you as having cardiovascular low, and not low and extra low. Or if you have heart failure and hypertension, same thing, we'll code you as heart failure. So the idea there is to reduce incentives for upcoding and the effect of upcoding. So I was talking about how some plans might be a little bit more aggressive in their coding than others, which will drive up their risk scores. This tries to mitigate some of that, so not to go and try to, if someone does have heart disease of some sort, we'll look for the most expensive feature of that, not like everything that's been checked off. So that tries to reduce the incentives for upcoding. Yeah. We look for over a year. A year prior, yeah. Well, there are two kinds of models. There's concurrent models and there's prospective models. So a concurrent model, you look at the diagnoses within a base year and you predict expenditures in that year. In a prospective model, you use the same diagnoses, but you predict expenditures for the next year. And there's a little bit of a philosophical debate about which one you want to do. But what it comes down to in concurrent models, because the cost, the dependent variable, is in the same year, the more you have higher weights on the coefficients, so you pay more for heart transplant, heart failure, and AMI, and you pay less for the intercept, for the base rate. So more dollars go into the diagnosis, where in the prospective model, when you're looking out to the future, fewer dollars go into the diagnosis. So a lot of the Medicaid plans have been doing prospective risk adjustment. The healthcare exchanges are doing concurrent risk adjustment. Kind of as these things get implemented, there's often a delay in implementing it. So even if you do prospective, it's hard to say, well, I've got all the diagnoses for this year and I'm predicting expenditures for next year. In reality, you have the diagnoses from a year or so, or two ago, by the time you kind of collect it all and analyze it. And so some people say you should just do concurrent, because really you're just taking a diagnostic profile from 2 years ago that you're hoping is pretty similar to what's going to happen this coming year, and then you just want to predict what expenditures are going to be in this coming year. So use concurrent. So you could use either one. So weights are additive across major categories. So you could have, say, cardiovascular disease and diabetes, and they would both count. Psychiatric and diabetes and so on. But you couldn't have, count like multiple psychiatric categories or multiple cardiovascular categories. So in addition to these diagnostic-based models, there are also pharmaceutical-based models that use NDC codes. Ours is called the Medicaid RX Model. I don't know, there's like a DC RX, something like that. But the idea is here is you take the NDC codes and link them to disease categories. And so in here, you're trying to, group NDCs that have similar pharmacotherapy approaches. And so we, combine, pharmaceuticals used for cardiovascular disease, used for depression, used for psychosis, and so on. And so it's a little bit different than diagnosis. In that diagnoses, you're identifying the clinical condition, and with the NDC codes, you're identifying the pharmacotherapy. But drugs can be used for different things. So a bit of a trade-off here if you're using like a NDC, a pharmaceutical identifier, it might not be exactly for what you are identifying. So I'm trying to think of a good example, but I don't know, bupropion is used both for depression and smoking cessation. And so we try to limit the ones that are in that category to the doses that are specific for depression, but it's not always that clear-cut, so you might have some people being prescribed that for smoking cessation that then get identified as depression. Similar, there's some seizure disorder medications that can be used either for seizure disorder or bipolar disorder. So again, it's a therapeutic class here. And we find they're pretty similar. I think we also have a combined model where we take 15 of the 45 drug categories and combine them in the hierarchy for CDPS to do a combined model. I think if you look at a TANF population, diagnoses and pharmacotherapy do pretty similar, because there you're looking at common chronic diseases for the most part, and a lot of that is treated by pharmacotherapy. And among the disabled population, diagnoses do a little bit better because you have kind of more specific illnesses driving utilization in that group. So I think diagnoses are better. Having the pharmacy in there is nice because you can identify things that aren't always well diagnosed. So hypertension, for example, once you're started on, say, an ACE inhibitor, you might not get a hypertension diagnosis every year, even though you're on the medication. So the medication kind of keeps you in there. Mental illness is another area where often the diagnoses aren't there. Either they're not added to the chart because of stigma or for payment reasons. They don't pay for a mental health visit, so they're not going to code a mental health diagnosis. Or if they're getting prescriptions from a mental health specialist that's outside the main system, like a carve-out or something like that, the data systems might not be feeding each other right. So that's an area, in psychiatric where you find that pharmacotherapy identifies more individuals than diagnoses. So that's where kind of a combined model is important. And as you think about the different things you're looking at, like if you are looking at behavioral health, you might want to consider that as well. There's different weights. So these are regression models. So the algorithm creates indicator variables that can be used as independent variables in a regression model where the dependent variable is cost. We talked a little bit about concurrent versus specific. You can also use the weights, which are the regression coefficients that come with these software packages to assign a risk score or severity score. Or if you have enough data, you can estimate your own coefficients. You need pretty fairly large sample sizes there. When we actually do risk adjustment, then we think about what's in the benefit package. So is this a comprehensive acute care HMO? That's kind of what this is built for. But sometimes even those will carve out pharmacy coverage, and that'll be delivered by, say, a pharmacy benefit management company. So you want to carve out pharmacy from your payment rate. Or they'll pay for OB separately, or they'll pay for certain, pharmaceuticals separately. Well, the hepatitis C medications, the expensive ones, they've been paying for that separately in some cases, and so on. So you might have like a customized weight set. And then we talk about here on the difference between prospective and concurrent. I do have a slide on the weights. So this shows you kind of how different categories might result in different risk scores. These are all normalized to 1.0, where that's the base rate. So here maybe for a disabled beneficiary, 1.0 could be, say, $1,000. So you're looking at paying, $2,000 per month extra for someone with, cardiovascular very high, or about, almost $1,000 a month extra for someone with psychiatric high, which is mostly schizophrenia. So that's schizophrenia, and then bipolar disorder, affective psychoses, and then depression. And so these are payments up and beyond kind of the base rate and or the intercept, and this is how you would calculate scores. So there's an intercept, like any regression model. When you do predictions, there's an intercept. We've got age and gender factors. So here shows you, for example, a 50-year-old female with type 2 diabetes and hypertension. The intercept is 0.225. The the demographic factor is 0.121. Then the type 2 diabetes would be 0.322, and 0.130 for hypertension. So you add them up, and that person would have a risk score of about 0.8, which is below average. So this is a disabled population. If all you have are diabetes and hypertension, you're not that sick relative to the overall average in the diabetes population. Now remember, the disabled population. So remember, expenditures are skewed, so it's a smaller number of people that are accounting for a large amount of the expenditures. So the mean will also be skewed to the right. That if you look at the same female with bipolar disorder, you add in that 0.626 factor, and then they're at a 1.4. So then they're 40% higher than the mean. And so if the base rate was $1,000 per month, then for this individual, the payment would be $1,400 per month. And so this is how we do it. You take the case mix score, calculate at the individual level, and wrap it up, predict it at the group level, and then do a case mix score for each plan, and then you multiply that by the base rate, and so on. And then there is an issue about, are you calculating, is this budget neutral? And at the federal government level, it's not budget neutral, so they're paying more and more each year for these Medicare Advantage plans. Whereas if you look within a state, often what they do is they say, well, this is the rate this year. This is the base rate. And then they divide that up among the health plans based on the risk score. So they're not paying like more this year if there's more, higher, if all the plans increase their coding and everyone's risk score goes up, they're not paying anymore. It's still budget neutral. They renormalize everybody to 1.0 before they start distributing the payments. If you don't make it risk neutral, then you you face increasing cost pressures over time. You still probably, most states do increase their base rates each year, but then they can do it more purposefully rather than letting the data decide how much they're going to spend. The actuaries get involved in this. They make all kinds of adjustments. They might do partial capitation. They might play around with risk corridors or reinsurance. There are different carve-out approaches. So if you really get into risk adjustment, then you start getting at some point into the weeds and dealing with all these kind of specific issues. And we usually give these to the actuaries to figure out. It's not very fun. So we consult on the development of the model, and then they do all the hard work of getting the data and calculating the scores and communicating it to the state and the plans and everything that's going on. So here are some things you're hearing about in healthcare, or hearing about, or have heard about for a while: the chronic care model, complex case management, accountable care organizations. We're looking at primary care medical homes, and now behavioral health homes, integration, and so on. And all of these things have some common elements. We're talking about team-based care. We're talking about care management. We're talking about increased IT. And risk adjustment fits well, I think, into these concepts, because if you have robust IT, that can support the data collection you need to do risk adjustment well. And then if you do risk adjustment well, it gives plans a lot more flexibility to how they invest those dollars. So instead of worrying about, you know, the primary care provider billing for everything, they can maybe focus on team-based care, maybe some, you know, use some lower cost providers in the mix to do some of the care management. You know, they can do phone calls, emails, things like that with a capitated payment. And they can have, you know, bring in different types of people and different types of care. So they can have some nurses focused on diabetes care and social workers focused on mental health and care transitions and things like that. So just to you know, summarize, you know, risk adjustment kind of is necessary in this environment of managed care and capitation. You know, some thought needs to be put in to have it be done well and result in equitable payments. It does seem to move money around, so I don't have any slides on that today, but you know, we do see money moving, and moving kind of in places where we expect people to be sicker. Data kind of remains a key challenge and will, but you know, it provides the opportunity, you know, reduces the incentives for risk selection, and then also provides the opportunity for plans to develop, you know, more kind of higher quality models without kind of worrying about its financial impact quite as much.